I'm Dr. Bates, and this is Musculoskeletal Minute. As an intern, I developed something of a reputation for really enjoying OMT and being pretty good at it. But it goes deeper than just thinking osteopathically and doing OMT. One of the true important aspects of it is the completion of a good physical exam and keeping a broad medical differential diagnosis in mind. I received a referral one day for a patient that was there to see me for low back pain and OMT. The other resident had said, "Hey, I think you might benefit from OMT, but in the meantime, I'll order you a lumbar spine MRI," and had the patient get scheduled with me. I saw the patient and dived right in on the history and the physical exam. The history was interesting, and the physical exam got even more interesting. This individual had weakness bilaterally in the lower extremities, but the left leg was more weak than the right, and there was also decreased sensation on the left that was more severe than the right. However, the right leg also had clonus when I checked their reflexes, multiple beats of clonus. And the concerning part too was that there was some upper extremity findings as well. This patient had brushed it off as being chronic bilateral carpal tunnel that was going on and that it was separate. But I kept a broad differential and also talked to some experts, which is always a good place to go. And I ordered a cervical spine MRI with proper documentation, and it was approved. Previously, a lumbar spine MRI was rejected for this patient, but this cervical spine MRI was approved. And the MRI found that they had severe cervical myelopathy or cervical stenosis. And, well, that was as much as we could do. They had a consult with surgery and then had to undergo some extensive cervical surgery. I admittedly don't know what the long-term results of this were. I graduated not long after this individual got surgery and moved to a different state. This goes and reinforces the idea of having a broad differential and completing a good quality exam and then documenting it. I highly value the physical exam, but how do you use it? I'm going to go ahead and talk about my ways to use the physical exam to guide the medical workup. A fun little fact about me is every MRI I have ordered has been approved and also found something. Though thankfully not all have been as serious and major of findings as this case, but here are my tips and tricks. 1, to keep a good physical exam in mind, but 2, to also get additional imaging covered when they are appropriate. So I think about my physical exam in 2 sections. The first is to find any red flags and indications for further testing, and then the second aspect of that is to figure out the diagnosis and or how to treat it. It would seem nice and easy to just order everybody an MRI. That way you wouldn't miss things like this. It would have been really easy to take a lumbar spine MRI and maybe find something about the case in the beginning. Basic statistics say that the person probably did have some findings in their lumbar spine, but they also had some massive findings in their cervical spine that were truly the cause of a lot of the symptoms they were suffering. So, why don't we just get an MRI on everybody? Well, 1, they're really expensive. And 2, it's the second-hand effects of getting the imaging and then finding results and then chasing down everything that is found on that. Because imaging discovers a lot of things for us, but it doesn't identify which ones of those are causing the pain or the disability at that time. If you find something that's not actually causing it and you have a treatment for it, and well, it doesn't help, so all of a sudden you've suffered from that testing, that treatment, and it still wasn't the part that was the problem in the first place. And they've done studies that show that patients, after finding out imaging results, tend to catastrophize and kind of perseverate on the results of that and say, oh, I have a disc bulge. It's my disc bulge. I won't be better. And there's actually a whole way of how it is interpreted as well, which is absolutely fascinating. I'm going to do a future podcast on this, but stuff that we think of as degenerative disc disease, oh, well, it's just a normal part of aging. A lot of patients actually interpret that as it's going to keep getting worse and I'm going to end up paralyzed and in a wheelchair. And that's not true. So we can save a lot of stress in that by ordering imaging appropriately. Other testing, such as the EMG nerve conduction study, is great, but it's time consuming and also carries its own risks, and people just don't like getting stabbed repeatedly with needles. So we need to determine when we order these tests. They have great utility, but they also have risks. We do have back pain treatment guidelines. It's great to have guidelines, but back pain guidelines should be history based, but they also need to have a basis in the physical. Also, an important part here, it's not the most important, but it is an important part. You need to have a good quality physical exam and proper documentation of the physical exam and the findings in order to justify ordering these expensive tests. Insurance companies don't want to pay for these things, so we got to make a convincing argument that they should pay for it. And how do we do it? Via the physical exam. So, how do we do this? Well, actually, I'm being that guy right now, and check out my videos on YouTube, Musculoskeletal Minute. I have videos breaking down how to do the lumbar spine exam and cervical spine exams. Both of those are less than 2 minutes, and it's a run through. Or that gives you a great chance to see what I'm about to describe. As I previously mentioned, I like to view the physical exam in 2 different parts. First, the red flags and indications for further workup. And again, second is what the diagnosis is and how to treat it. But these red flags and further workup, muscle strengths. Generally, you're comparing side to side. I mean, think about an old lady coming in versus a bodybuilder. If the old lady is strong and equal on both sides, it doesn't matter that she's not as strong as the bodybuilder. But if the bodybuilder, one leg or arm can push you away, and the other one they can hardly lift up, there's a problem there. I actually saw a really interesting patient. This individual was going through training or getting ready for training to be special forces in the military and had a Brown Séquard type injury. I can't remember what it was from, but had a Brown Séquard injury. So there's a strength difference between sides, and then there's also sensation differences. It's a very interesting situation. It was great to see it in real life, but not in a textbook. But I was kind of lulled into a false sense of security thinking, oh, there's going to be some weakness here. Yeah, no, this dude still was able to push me out of the chair with his weaker side. Why? Because he was training to be a special operator before, and he wanted to get back up to a level of fitness. But his strong side was definitely much stronger than his weak side. So you got to compare things. Keep that in mind. Reflexes, again, what is a 1+ versus a 2+ versus a 3+? Well, the really big ones are, what if the reflexes disappear? And what if there's clonus? If you got one of those are definitely things to look into. And what if they're kind of dull and not very reactive on one side and hyper reflexive on the other side? Again, things to look forward to. Overall balance. Are they the same both sides? Are they fairly similar reaction time between upper and lower extremities? Sensation, go ahead, check that. Spurling's maneuvers and straight leg raise, I always do these. Even when I am seeing a patient for the 3rd or 4th visit for osteopathic manipulation, neck pain, headaches, I always just check a Spurling's exam or a straight leg raise. They're easy enough to do, and they actually have a lot of information that you can tell. The important part is that it is in a dermatomal pattern when there is pain or numbness and tingling or stretch. Actually, with the straight leg raise, stretch many times is a distractor because so many people have tight hamstrings. But usually stretching and tight hamstrings is going to be more of a bilateral thing, and there's resistance for you as you're picking it up. Whereas a positive straight leg raise has a lot more of a zinging pain down the leg. And there's actually a backwards version of the straight leg raise. I can't remember its name right now, but basically you do hip extension and it will check the upper lumbars in kind of the same way that the straight leg raise does. And then The Spurling's exam, the positive again is the dermatomal pattern. If there is axial pain or if there's pain in the traps, it is not a positive Spurling's. And as such, I document that axial pain with Spurling's or radicular pain with Spurling's, positive Spurling's with radicular pain. That's how I document it to make sure that I'm specific. And then same with that, the Babinski sign, I always document that as a downgoing Babinski, unless it's not downgoing, and then I say that there is an upgoing Babinski. I do that as opposed to positive, negative. I want the next person reading my note to know exactly what it did. Those are all the red flag and further imaging. Pretty much, if these are positive, then it's time to definitely be considering what the next stage in working things up is. But for me, if those aren't negative, I move on to my diagnostic exam, which includes things such as the osteopathic structural examination, diagnosing the movement of the different vertebrae or the pelvis and so on and so forth. And then also stuff like the shoulder tests and hip tests. Though I will say if it is hip pain that we're looking at, the hip test can kind of go in more of the and further imaging, especially if they have groin pain with like the Faber test. But that one's kind of an in the middle one. But generally shoulder tests and things like facet rotation tests and loading, all of those I generally have more in my diagnosis mindset than I do have a red flag mindset for those. Though please remember, in trauma, go with validated tools such as the Ottawa ankle and foot rules or the C-spine rules such as Nexus or Canadian. These are validated for trauma. If you do these things, you do a good thorough exam, and you kind of keep this mindset. One, your patients are going to be happy that you actually examined them. It's amazing how many patients actually notice when you don't examine them and they comment on it and they actually like being examined. You do all of this and you appropriately document it, insurance is much more likely to be approving the expensive tests that you're going to be ordering, whether it's an MRI or an EMG nerve conduction study. And fortunately, yet unfortunately, you're probably going to actually find something, and it's going to be something that you're actually looking for because you've done this, you've thought about a differential, and you've ordered appropriate tests. When you do that, you're much more likely to find something than if you just say, back pain, okay, go ahead and do this. But the good thing is you're going to find it, and they're going to have the clinical findings to go along with it, and you're not going to say, oh, hey, look at this, there's a disc bulge. But they're 50 years old, and so there's a 60% chance that they were going to have a disc bulge anyways. So at least you are finding things that have a clinical relevance to it. This way, you will be able to responsibly use both the money and the patient's time and be able to get better outcomes this way. Won't be going down testing rabbit holes based off of incidental findings, but we'll actually be able to go off of the actual clinically significant findings. Take these, use them, it's great. It is so fantastic that we have all of this technology, but please let's not forget that we actually have great technology of our eyes and our hands, and we can actually do a good physical exam, and more likely than not, we can place a bet and then order the exam and see if we're right. Actually, that comes up to one last little point here, especially with ordering. Don't be afraid to put down your differential diagnosis, or at least concerned for cervical myelopathy when you're ordering that cervical spine MRI. It helps insurance validate what it is that they're looking for, and it also helps the radiologist be like, yep, that's definitely what I'm looking for. So don't be afraid to actually help out your teammate, the radiologist. Hopefully you found this useful. Please go ahead and subscribe to my podcast. Leave me a good rating. And then also reach out to me with things that you want me to talk about or videos that you would like me to make for YouTube. Check out my YouTube channel for examples of these physical exam maneuvers, but then also how to treat them. Reach out, connect on social media. I'm on both Facebook and Instagram. I would love to know the things that you are encountering in every day, things that you have questions about, ways that we can work together to learn and be able to ultimately help our patients that are suffering in pain. Oh yeah, go ahead and share all this with others. Please don't be a gunner. We're all on a team in medicine. I know it doesn't feel like that while you're in med school, but everybody is on a team working together to help our patients. So go ahead and share. When the patient wins, we all win. Thank you for joining us on Musculoskeletal Minute. We have your back. Please remember that this is for education and does not constitute medical advice. Please subscribe, leave us a positive review, and share with your friends.